What is the most common RPM peripheral? And I'll open it up to both of you guys.
I would say that probably depends on what fields you're in. I would say for myself personally, I mainly support people who are living with diabetes, and we use a lot of glucometers and we use a lot of continuous glucose monitors, which has provided some really interesting and great data to review on a regular basis with people. Those are probably the two most common I engage with.
Yeah, majority, or I feel like some of the most common applications for an RPM program, is diabetes and then also congestive heart failure. Now, RPM is rolled out to tons of different conditions, but those were some of the some of the early use cases and one of the most consistently used now. So, kind of including the blood pressure cuff along with that for the congestive heart failure patients as well.
Sure. And I'll just chime in and say that there's been a lot of advancements in a lot of technology, right? But weight scales is another one, right? So, in our video, we show all three of those devices. And I find that in our region, at least, health systems and health centers that are using RPM sort of attempt to provide the patient with all three of those so they can get, the full range of biometrics and be best informed. So we have a great question. Yeah, that'll work. What are we using for congestive heart failure and COPD? Cam, do you want to start with that one?
Yeah, at least for the congestive heart failure, a lot of times they're kind of combining utilizing blood pressure cuffs as well as weight scales for that particular population and just monitoring their blood pressure specifically to make sure it's not moving into, that hypertensive crisis blood pressure range. And so that's, what I've found most with the congestive heart failure. COPD, I'm not as familiar with. There are pulse oximeters that individuals use that are with that. I'm just not as familiar with those particular types of programs. So if Jennifer or Reed have any additional context on that, feel free to chime in.
Jennifer, do you have any? If not, I have some that I was going to sort of give you a throw out. And I was going to pivot towards the question that we have here. So maybe I'll just do that naturally. I would say exactly what Cam said. I will also say that the wearables, for lack of a better word, in technology is a field that sort of blossomed and bloomed throughout the past 2 years of the COVID public health emergency and some of the relaxed permissibility and surrounding telehealth services. And I'm excited to see what is out there. I know there's a couple of vendors here today that have been working on wearable sort of O2 readings and other, lung capacity measurements. But I also think that that's something that the FDA approval process for wearables is not that old, right? So there's a sort of small window of time where you've had companies have the ability to develop that tech. So I think it's going to continue to go. But when I think about that question, and Cam started to touch on it, and this question that we have on our screen touches on it, and I know Jennifer has shared some great insights with me on it when we've talked about it before, it kind of comes down to the data that you're collecting and how you're setting up the interaction with the patients. Like what's a high... What are you deciding is a high threshold? What are you deciding is like the sort of minimum threshold and so on and so forth? And then how do you manage working through that? And so, Jennifer, I don't know if you want to start with your experience of sort of, dealing with all of this data. And then Cameron, if you want to pop in.
It is a lot of data. So you have to be strategic in how you want to interact with that data and how you want that data to flow to you. We have an alert system set up. So when people have blood sugar readings that are really high or really low, that will create a trigger to me as their diabetes educator. And I will see those triggers come into our system in my provider view immediately. So that if I'm there, I can pull that person up, I can triage who I have in my alert buckets and decide who needs to be supported first. So we really rely heavily on that system so that we're not constantly combing through the weeds of all of the data to figure out who needs to be addressed first. But I will say there's also a benefit to looking at data that's not necessarily triggering in. So looking at the data that's really great too. This is a good opportunity to jump in and give people really quick kudos for things that they're doing well and to highlight some of the the positives and reinforce, what's happening this day where your readings are in range 20 hours out of the day. What did you do that day? Let's try to do more of that rather than only focusing on the alerts that come in.
Yeah, and to kind of piggyback on that too, I think when you think of patients consistently giving biometric values to a provider, it's kind of easy to think, wow, that's going to be an insane amount of data that I'm going to have to look through an Excel document to try and figure out, where their value was on what day. There's been a lot of innovation when it comes to, um, how do you get alerts whenever patients kind of fall into a certain range? So it takes a lot off of the provider's plate on needing to, heavily manage that data personally. You can kind of set the sensitivity of the alert. So, if you only want alerts whenever a patient goes within a certain threshold, that can kind of help with feeling overwhelmed with the amount of alerts or data that's kind of coming through as well. So, it's not just you're going to get this overwhelming amount of data and you're going to have to figure out what to do with it. There's been a lot of innovation in that to make it really easy for providers to be able to utilize it for the benefit of both them and for their patients.
So Jason asked this really great question in the chat. Do you use any sort of logic or criteria to select patients who would be good candidates for RPM, or do you sort of assume all of your patients are eligible for it?
So I would say that, I think anyone could benefit from this. It is really great, innovative technology and a new way of approaching care for people. If you did have to kind of pick and choose who you opened the door for this to participate in, then I might think of people who have limited access. Maybe it's really hard for them to get to a provider's office. Maybe they go really long periods of time in between visits or no show often. Anyone that you think would benefit from having more touches, more interaction in that space in between visits. I think that those are the people I would really hone in on and try to get into a program like this so that you're not going long periods of time knowing that they're high risk and things could be happening that you may not have time to address once they finally do get to the office.
I would say that is how a lot of folks in our region have sort of gotten their RPM programs established, right? Is exactly what Jennifer is sort of looking at. Is like you look at your patient profile and you try to identify the folks that you sort of either I recognize that you're not getting as many interactions with as you'd like, or that you can see that it would be the greatest benefit to them as well, right? Like if they're traveling 45 minutes each way to interact with you, and you can start getting more constant data and set them up with some sort of video interaction, that's a mutual gain for both of you, right? And then over time, maybe you get more devices and you develop more materials, and it becomes sort of a resource for all patients. All right, I will. Perfect, yeah. So Jennifer, how do you deal with coverage overnight and on the weekends?
That is a good question. It's all about setting expectation. And you have to decide up front what you want your program to look like. There are certainly programs out there that are available 24/7, and that's the precedent that they set with people who they have in their programs. And in those cases, they staff 24/7, and they are usually considering themselves to be emergency services where they will respond within a certain time frame when an alert comes in. But you can really dictate what your model looks like. We are only available Monday through Friday, and we set that expectation with the people who are in our program. I let them know when I'm available and when they might expect to hear from me, and you just have to kind of stick to those expectations. If you aren't going to be an emergency service, you want to make that very clear so that people aren't expecting that as soon as they have a high or a low blood sugar reading, they're going to hear from you within a half an hour or an hour or over the weekend. So just decide, what you want your program to look like, and then make sure to set those really clear boundaries and expectations with the people in the program.
So I'm going to chime in with one of my own questions here. We've talked about this sort of offline, and I think it ties in well here. In terms of the protocol process, whatever you want to call it, internally, right? When you get an alert, can you talk a little bit just sort of about the triage process that you work through? And then Cameron, if you want to talk about any experience you have with other sort of, workflows in terms of which medical provider may interact with the patient based off data readings.
Yeah, so we have coaches who are responsible for the day-to-day, the most frequent interactions with our members, and then we have a triage system. So if there's something going on with the member that they need a different level of care that's out of the scope of our coach, then that would be escalated to, say, myself as a certified diabetes care and education specialist, or we might escalate to a pharmacist or to a mental health provider on our team, or we might even take it further and escalate it to one of our doctors so that our endocrinologist, for example, can step in and participate in the care for that member. So we have a really diverse team. We have a lot of different disciplines involved in our team that work together to support the people in our program. And we rely heavily on our frontline coaches to know how to escalate and triage to the appropriate provider if there's something more critical going on.
Yeah, and the program that you are currently running will dictate a lot of what that may look like too. And so, if you're working on a if you're working with a congestive heart failure population, there might be a different level of urgency of reaching out to that patient depending on the biometric value that kind of came through, as well as Jennifer said, the diversity of the individuals that you have on staff. So, there's a lot of adaptability for your RPM program. And, there are programs that are combining multiple disciplines. So, being able to utilize coaches, care coordinators, utilize mental health professionals to address mental health needs related to those conditions. There's a lot of, variation to what that triage process could look like based off of what you want your program to look like, as well as, the capacity that you have to take those on.
Yeah, so we have a question here. Have you used any remote patient monitoring without providing devices, without providing peripherals? Maybe through a regular phone, smartphone sort of utilization, or any other sort of use your own devices. Maybe they pick them up, at an electronics store. That is happening more and more these days. Do you have any experience with that?
We primarily rely on the devices that we send out to people. We send out a variety of devices and they connect directly to our program. So that's how we get most of our data. But I will say that sometimes our members will find that if they can get insurance coverage for a different type of CGM than what integrates with our program, that I can still see that data if they give me access to, say, their Dexcom Clarity or their Libre View. There are oftentimes provider views for many of these devices that people can give you access to so that you can chime in. But again, those aren't going to come through an alert system or be as easily triaged. So you just have to consider that.
Yeah, additionally too, if you're utilizing some of those mobile applications without utilizing the device, depending on the insurance carrier, that can, create some barriers when it comes to reimbursing for those services. Medicare specifically does require an FDA approved device in order to furnish and bill for those RPM services. So that's something to keep in mind as well. If you're not utilizing those FDA approved devices, it may come as an additional cost for that patient to utilize that service. And that kind of rolls into another question that I saw on here, Reed. So about, coverage for insurance with that. So I kind of talked, a little bit about the Medicare. And so for Medicare too, it's important to note that during the public health emergency, some restrictions related to remote patient monitoring have been lifted. So we hope to see those restrictions lifted long term. And so that's just a little bit about Medicare. Reed, you want to talk about what Medicaid for your region, and a little bit on the private insurer, and then I can talk about Medicaid for my region.
Sure. Yeah. So to Cam's point, it is important to really be aware of what insurance your patient has when you're looking at these devices and various avenues of telehealth. Really, I think. For our region, I would say that we are lucky in the sense that the majority of our states do have established protocols within Medicaid, and therefore our private insurers and the state statutes allowing for RPM devices. It is for the private insurers, much like Medicare, they're going to have a list of devices that they will allow. For the state Medicaids, I don't know offhand if they'll provide lists, but I'm sure that you could connect with their office and they would provide you with some that they have approved in the past. Yeah, and so I think unfortunately, you're really there's no easy answer, in my opinion, right? You're going to want to know what care avenue you're looking at, what insurance your patient's sort of bringing to you, and then decide. That being said, I do know, to Cam's point, start with the FDA approval, right? I know there are FDA approved devices that are cutting across all three of the major insurer sort of buckets in our region.
Yeah, and when it comes to the Midwest, the upper Midwest, when it comes to Medicaid reimbursement, it's pretty limited within our 4 states. So there's very specific patient populations and settings that it's approved to be utilized in. So especially if you're looking to roll out a remote patient monitoring program, if Medicaid is a patient demographic that you really want to focus in on, you might want to check some of the state requirements for our region, since there are a lot of stipulations currently that we hope, will expand over time. But you want to make sure that if Medicaid is something that you're really wanting to treat, that you're looking at the right patient population.
And then I think for a final thought on that, our colleagues at CCHP do provide some really nice, detailed maps and other, tables of information on the sort of permissibility of RPM across the nation. So definitely check that out. And then I would also say that, I think both Cam and I were thinking it, but neither of us said it out loud. Chronic care management, right? For those of you that are familiar with the CMS codes, that is the biggest bucket where RPM sort of, if all the PHE flexibilities went away, what was you could use RPM within? It's chronic care management. That's sort of the pretty well established route for these care services. One of the neat things about the last 2 years has been able to sort of see the various new avenues where this could apply. And so I think we all have our fingers crossed that continues to be the case. Kind of harken us back to the video for a little bit, so Jennifer can share some insights on something that I thought was powerful. In the video, Jennifer, you really did a nice job of prompting Kathy to have some self-realization, for lack of a better word, right? Kind of guiding her towards enlightening you on what might have caused some of these higher metrics and higher readings. And I was just curious if that's how you've learned that trick. Is that something you find really useful? Is it something you're constantly refining? And your thoughts on that?
Yeah, I'm not sure where it entirely developed from, other than just experience and training over many years of doing this. But I've found that if you approach interactions with people with a sense of curiosity and almost put it on them to initially share what their thoughts are and what their theories are on why things may be the way that they are, 9 times out of 10, they know a lot about what's going on, maybe even more than I do. I mean, I can look at data and usually pinpoint what some possible explanations might be, but if I can get them to verbalize that and reflect on that and speak to that and share it with me, then they tend to feel a lot more empowered and engaged in their own care. And I've just found that people really respond positively to that and appreciate having that opportunity to share their insight and expertise, because they're experts on themselves. They know themselves better than I ever could. So they will oftentimes share things that are very enlightening and very spot on with what I may have interpreted from a clinician standpoint.
And do you feel with that, Jennifer, that, if you were trying to have that conversation without, being able to utilize the RPM technology or having that data available, that it would be a lot more difficult to get that patient to kind of come to that realization?
Yes, definitely. Because I haven't always practiced in this space. I did practice a little more traditionally before I moved into telehealth and RPM. And I would say that their ability to see this data, to know that I'm seeing this data and to reflect on it more regularly, really, again, brings that sense of empowerment and autonomy to them interacting and engaging with their own data. So by being able to pull that up on a screen and look at it together and say, this is really interesting data. These are interesting trends. What do you think about this? It prompts them to be more engaged in that data and reflective of it and more thoughtful about why things may be looking the way that they are. And that's really challenging to do if you can't do it regularly. So repeating those types of interactions and that look at the data multiple times. And usually in a typical visit, you don't have time to pull up a lot of data and really dig into specific things. Whereas in these cases, it's all about not only meeting people where they are, but meeting them where they are when they're there. And that I've found can be really powerful and just bring a lot more value to them and to their data. And if they see value in their data, they're more likely to provide that data and to take the steps to check their blood glucose or to wear a continuous glucose monitor so they can continue to see and evaluate that data.
Yeah, absolutely. Being able to make those connections happen versus, if you're just sitting down with a patient and just kind of talking to them, it brings a lot more clarity and, how different situations that may happen in their life or, different choices that they make does impact their health. And having a very tangible way to be able to show that versus, well, tell me about when you felt this way, what was kind of going on. It's a little bit, more vague, whereas here you can be a little bit more concrete of, what was happening on this day that you think might have elevated your blood pressure. So to be able to have some of that information to go off of, I feel like really helps open a lot of doors for those patients.
Yeah. And I think it does come back to not only focusing on those things that maybe aren't so great, but focusing on the good things too. I noticed your readings looked fabulous today. What was going on that day? What worked well for you? Let's do more of that. And that really seems to resonate quite a bit with people, and they feel more comfortable with you as their provider and really get excited about making changes and taking care of themselves.
And as somebody who has perpetually way too much going on, I'm sure if I was in this scenario that my PCP would like to be able to maybe do it in a little bit more real time, right? Like asking me to recollect on 3 months ago is not conducive for this personal patient right here, right? And so I think that that's something I could see a lot of value in. Before I wrap us up, I do want to give you both a chance to correct me on a question that I answered in the chat. And Jennifer, this would obviously be based off your experience, and then Cameron off your experience with your region. Do you have any experience or knowledge of RPM services being provided by somebody who is not the patient's PCP or the PCP entity?
So by that, are you referring to other programs outside of the PCP office that the person might enroll in to have those?
Sure. Or like, do you provide services for anybody that's not already sort of directly under your group's, triangle of care, if you will, coverage of care?
So we tend to support people almost as an add-on to their primary care services. So they might have a primary care provider and team who they engage with as they normally would. And then our program set up as kind of an additional virtual care clinic that they can enroll in so that they would have access to our team in between their PCP visits, in between those other visits that they would traditionally have. So we're kind of like an added bonus to tack on to what the traditional model might look like.
Yeah, I know some different hospitals that, have more of a population health focus, have kind of taken this outside of, out of just the primary care physician being a part of it. They have like teams that are dedicated specifically towards, when we have patients with X diagnoses that come through our door, like we're trying to get them plugged into these kind of, like Jennifer was saying, like additional programs that are outside of it that kind of fall outside of maybe having their primary care physician at that particular hospital. Especially with congestive heart failure, when you're trying to reduce readmissions within that 90-day time frame. Time is kind of the essence. And so being able to connect them to a program immediately versus maybe having to go through a channel for a PCP. I have seen some hospitals take kind of that standpoint because they're looking at it more from a cost avoidance standpoint. And so there is some that are kind of, taking that angle. But, obviously a lot that are combined with the primary care physician. And especially long-term, being able to have that relationship with the primary care physician with that program is going to be mutually beneficial.
And I would say just with insurance companies. So a lot of these external programs, these virtual clinics in different disease specific programs have relationships or contracts with insurance companies to provide their program as a benefit to anyone enrolled in that insurance program. So you may have people who come to you who have certain insurance plans that give them this benefit, and they may not even be aware of it.
Sure. Yeah. And so I think both of those sort of touch on the example I was thinking of, which is, outpatient follow-ups, right? Like after procedures. I know of hospitals that are using it to sort of monitor the patient, but then they also use that to transition it towards a long-term program. I will say that at least the reason why I was hesitant to do a blanket statement on that is just due to policy, right? And so because we are at time, I'll leave it at that. Just due to policy, check it on the state you're in. And as Jennifer said, check with the insurers. The information's there, but it definitely is varying a little bit across the 50 states.